Okay, let's unpack this. Imagine, for a moment, a world where nearly 13,700 children under the age of 5 die every single day. That's a staggering, almost unimaginable number, isn't it? It's a stark, almost painful reminder of the profound health challenges facing so many of the world's youngest and most vulnerable. And it really compels us to ask, why? Why, in an age of incredible medical advancement, are these numbers still so tragically high? And crucially, who is most affected? Today, we're embarking on a deep dive into some truly critical information, drawing from a key chapter on global child health from a comprehensive, highly authoritative pediatrics textbook. Our mission isn't just to skim the surface, it's really to master this information, to understand the intricate landscape of global child health like elite professionals in the field. So you walk away not just informed, but with those profound aha moments that connect seemingly disparate dots in surprising ways, giving you a truly nuanced professional level grasp of these issues. This isn't just about statistics, it's about understanding the intricate web of factors that determine a child's fundamental chance at life and health. From the individual level all the way up to global economic structures and political will.
That's precisely what makes this deep dive so fascinating. What we're looking at is how deeply interconnected factors, some obvious, some incredibly subtle, intertwine to shape the health outcomes of children worldwide. We'll connect the dots between the big picture global trends and the very real on-the-ground challenges that impact families and communities daily. And the source material itself, it's a robust factual overview from a recent highly regarded textbook. So our discussion is firmly grounded in expert knowledge. We're not bringing in any outside opinions or new data. Our focus is really on peeling back the layers of understanding within this comprehensive text.
Absolutely. So let's begin by really digging into the global snapshot. This first section is all about understanding the overarching child mortality trends and, critically, the deeply troubling disparities that, despite significant progress, still persist. Okay, so when we talk about gauging child well-being on a national scale, there's one incredibly powerful metric that serves as a cornerstone: the Under-5 Mortality Rate, or U5MR. It's more than just a raw number of deaths. It's a profound, almost poetic indicator of a nation's overall health. It reflects the robustness of its healthcare system, the efficacy of its social programs, and its broader economic development. What's genuinely encouraging initially is the long-term trend. Our source tells us that globally, the U5MR actually fell by an impressive 61% between 1990 and 2020. That's a massive achievement, isn't it? It shows that focused global efforts can and do make a significant difference.
That 61% global reduction is a monumental achievement, no question. It reflects decades of concentrated effort. However, the stark reality is that while progress has been made, the burden remains immense and, critically, it's disproportionately distributed. Despite that impressive global drop, in 2019 alone, an estimated 5.3 million children under 5 years of age still died worldwide. To truly grasp that, consider this. That's equivalent to about 37.1 deaths for every 1,000 live births, or, as you pointed out right at the top, nearly 13,700 child deaths every single day. It's a number that continues to challenge our collective conscience, really.
And it's not evenly spread across the globe at all, is it? It sounds like this burden falls overwhelmingly on specific low and middle income populations.
Precisely. The source material highlights a staggering, almost heartbreaking concentration. 82% of all child deaths worldwide occur in just two regions. Sub-Saharan Africa accounts for a shocking 55% of all child deaths, and South Asia contributes another 27%. To put that into perspective, compared to high-income countries, where less than 1% of child deaths occur, the disparity is truly profound. A child born in sub-Saharan Africa, for instance, is over 15 times more likely to die before reaching their 5th birthday compared to a child born in a high-income country. It's a direct reflection of where resources and support are most desperately needed.
That's an astonishing difference, truly. But what's even more telling is that these aren't just disparities across continents, are they? These huge gaps in child survival can exist even within countries, kind of masking the national averages.
You've hit on a critical point there. If we connect this to the bigger picture, these national averages often mask critical inequities within countries. They starkly highlight where interventions are most desperately needed, often right under our noses, so to speak. Consider the example of Nigeria in 2019. The national U5MR was 117 deaths per 1,000 live births. Okay, a high number. But when you dive into the subnational data, the weights range dramatically, from a relatively lower 58 deaths in some areas to a devastating 261 deaths per 1,000 live births in others. This vividly illustrates that even within a single nation, a child's chance of survival can vary massively, simply based on the specific region or community they are born into.
And it's often in those very first moments of life that children are at their most vulnerable, isn't it? The data from our source really zeroes in on this.
It absolutely does. While overall child deaths have seen significant declines, the very first month of life remains exceptionally perilous for millions. The textbook reveals that nearly half of all under-5 deaths, approximately 2.4 million in 2019, occurred within that first fragile month. This translates to a neonatal mortality rate of 17.9 deaths per 1,000 live births. What's particularly concerning is that the rate of decline in neonatal mortality has been noticeably slower than the overall U5MR decline. This means that neonatal deaths are now accounting for a larger proportion of all under-5 deaths, reaching 48% in 2019, basically because deaths in older children have fallen more rapidly.
Right. So if I'm understanding this correctly, even though low and middle income countries might have a smaller percentage of their overall child mortality concentrated in those neonatal deaths compared to high income countries, the absolute number and the absolute risk of a newborn dying there is still exponentially higher. Is that right?
That's a crucial distinction you've captured perfectly. A child born in sub-Saharan Africa or Southern Asia is still 9 times more likely to die in that critical first month of life than a child born in a high-income country. So, while HICs might see a higher proportion of their fewer child deaths occurring neonatally, the sheer volume of absolute preventable neonatal deaths in LMICs remains staggering. It just underscores the urgent need for targeted interventions in those regions.
And there's another category of loss that often gets even less attention, tragically, and that's stillbirths. The source highlights this as a significant, often overlooked burden.
Unfortunately, yes. The scale of stillbirths is immense, yet it remains largely invisible in public health discourse. An estimated 2 million stillborn deaths occur worldwide every year. We're talking deaths at 28 completed weeks of gestation or more. That translates to a heartbreaking 13.9 deaths per 1,000 births, or the loss of one stillborn baby every 16 seconds. What's particularly concerning about these figures is that they're almost certainly underestimates. Stillbirths are notoriously underreported. It reflects a historical low prioritization of this vulnerable age group within global health metrics. It's quite shocking, really, to realize that before 2006, no major organization even published global, regional, or country-specific stillbirth rates, just highlighting a profound systemic neglect.
Wow. And if the numbers are already so high, it sounds like progress in reducing stillbirths has been incredibly painfully slow.
It has. The annual rate of reduction for stillbirths between 2000 and 2019 was estimated to be half that for neonatal deaths, just half. This slower pace means these tragedies continue at an alarming rate, and just like with overall child mortality, almost all stillbirths, a full 98% occur in low and middle-income countries. 3/4 happening specifically in sub-Saharan Africa and South Asia. This isn't just a number, it's an immense silent burden of grief and loss for families and communities who often receive little to no support and whose tragedies frequently go uncounted.
So, armed with these sobering numbers and a clearer picture of where the burden lies, let's drill down into the why. What are the specific leading causes of child mortality and disability that our source identifies, and what truly stands out when we look at this list?
Well, what immediately jumps out from the data is the immense potential for intervention. Most childhood deaths are from conditions that are actually preventable or manageable with relatively simple, low-cost interventions. The textbook highlights that the most common causes of death for children under 5 are preterm birth complications. Babies born too early intrapartum-related events, which are issues during childbirth, pneumonia, and diarrhea. In 2019, infectious diseases alone accounted for a staggering 2.61 million under 5 deaths. And a significant portion of those, 21.7% of all child deaths, were from vaccine-preventable diseases. Think about that. Neonatal disorders, encompassing a range of conditions affecting newborns in their first month, accounted for an estimated 46% of all under 5 deaths.
So it's not these exotic, untreatable illnesses for the most part, is it? It seems to really underscore the immense potential for improvement precisely because these are conditions we largely know how to prevent or treat.
That's a critical distinction, especially when you contrast it with high-income countries. In developed nations, child deaths from infections are far less common. Instead, injuries and congenital malformations account for a higher proportion of under 5 deaths there. This difference profoundly underscores the transformative impact of basic public health measures, effective vaccination programs, and widespread access to quality care. It's a stark reminder that so many of these deaths are not inevitable.
And undernutrition emerges as this huge, silent, underlying factor in so many of these deaths, almost like a foundational weakness.
It's absolutely foundational. Undernutrition, and that covers everything from fetal growth restriction and stunting to wasting and micronutrient deficiencies, contributes to a staggering 45% of under 5 deaths. Beyond mortality, it significantly drives poor childhood development in low and middle-income countries. It creates a vicious, self-perpetuating cycle. Inadequate dietary intake directly lowers a child's immunity and damages their mucosal lining, making them far more susceptible to pathogens. Then, recurrent illnesses further impair a child's appetite and their ability to absorb adequate calories and nutrients, deepening the undernutrition. It's a terrible loop, and the devastating consequences don't stop there. Undernutrition early in life can have profound, long-lasting effects. Impaired cognitive ability, significantly reduced school and work performance throughout life. It just perpetuates a cycle of poverty and poor health across generations.
And low birth weight plays a massive, disproportionate role in neonatal deaths, doesn't it?
It certainly does. Infants born with low birth weight are at an extremely high risk of death, contributing to 60–80% of all neonatal deaths. The vast majority of these infants are either premature, born before 37 weeks, or they suffered from fetal growth restriction in the womb. The timing of stillbirths also tells a powerful story about the quality and accessibility of care. About half of all stillbirths occur during labor, and this figure varies dramatically, from a low of 10% in developed regions to a shocking 59.3% in South Asia. This contrast profoundly highlights the crucial role that timely, high-quality care around the time of delivery can play in preventing many of these tragic and avoidable deaths.
Okay, moving beyond the youngest children, the textbook also highlights the older cohorts. What about children between 5 and 14 years old? Their mortality rates are lower, sure, but they're still facing significant and different challenges.
Indeed. While mortality among children aged 5 to 14 is significantly lower compared to the under-5 group, it's still a substantial and often overlooked burden. In 2016, 1 million children in this age group died. That translates to about 3,000 children dying every single day. For this older age group, infectious diseases play a much smaller role. Instead, the leading causes shift dramatically. Injuries from causes like drowning and road traffic trauma account for more than a quarter of these deaths. And non-communicable diseases, conditions like asthma, diabetes, certain cancers, account for about another quarter. So the causes of death evolve as children get older, but the threat and the need for targeted interventions remains very real.
And child health isn't just about survival, is it? It's profoundly about the lifelong impact of illness and disability, which so often goes unmeasured.
Exactly. Our source emphasizes that child health should absolutely not be assessed based on mortality rates alone. Children who survive severe illness or trauma are tragically often left with lifelong disabilities. This not only burdens their families with significant care needs, but also drastically affects their potential for economic productivity throughout their lives. The data is sobering. Approximately 1 in 10 children are born with or acquire a disability, and a staggering 80% of these disabled children live in low and middle income countries. The leading causes, things like neonatal disorders, infectious diseases, various forms of protein energy and micronutrient deficiencies, hemoglobinopathies like sickle cell anemia, and injuries.
And the impact, heartbreakingly, extends to mothers and families, which is a dimension often overlooked in statistical analyses.
Absolutely. Child deaths can, in profound ways, also lead to long-term disability in the surviving mother. A particularly heartbreaking example cited in the text is a woman who experiences a stillbirth, who is then at tragically high risk of developing an obstetric fistula, a severe birth injury, or even death herself. The numbers are stark. An estimated 78–98% of women with obstetric fistula had a stillbirth. Beyond the physical toll, there's immense, often unspoken psychological trauma: stillbirth, neonatal death, the loss of an older child. These can lead to severe PTSD, chronic depression, anxiety, debilitating guilt, and in some cultural settings, profound shame and social stigma, particularly for the mother. This has a significant and lasting impact on the health and well-being of the entire family unit. And this raises an important question, doesn't it? How do we truly measure the full burden of child health issues when the impact extends far beyond immediate mortality, touching generations and mental well-being in such profound and often invisible ways?
That's a critical point, because the ripple effects are immense. And then there's the adolescent cohort, those aged 10 to 19 years, which our source describes as a crucial, yet often profoundly neglected period in global health strategy.
It is indeed a crucial, often overlooked bridge to adulthood. Adolescents, who have ideally benefited from the gains in child survival and are now entering a critical developmental stage, often find themselves in social settings where significantly less attention and fewer resources are devoted to their well-being compared to their earlier years. This paucity of support during the transition into adulthood diminishes the overall long-term impact of those earlier child survival gains on their adult lives.
How significant is this age group on a global scale? I imagine it's a substantial portion of the population, especially in some regions.
Very significant. Adolescents made up 18% of the world's population, about 1.8 billion individuals back in 2010, and that number is projected to increase to over 2 billion by 2050. Critically, the vast majority, 88%, live in low and middle-income countries. Sub-Saharan Africa, in particular, is projected to have more adolescents than any other region by 2050, making investment in this group there particularly strategic.
So even though their mortality rates are considerably lower than those for younger children, adolescents still face a unique set of substantial challenges that are critical to address for long-term health outcomes.
Absolutely. In low-income countries, adolescents confront a daunting array of challenges. A pervasive lack of educational and employment opportunities, significantly increased risk of injuries and violence, high rates of HIV and AIDS, burgeoning mental health problems, and the often intergenerational consequences of adolescent marriage and teenage pregnancy. These challenges fundamentally prevent them from attaining their full potential as they transition into productive adulthood.
And you mentioned this period is key for the intergenerational transmission of poverty. That's a profound insight from the source material.
It is. The decade of adolescence, as our textbook highlights, is a critical period where poverty and inequity frequently transfer to the next generation. This is most apparent and tragic among undereducated adolescent females. In many parts of the world, poor teenage females are highly likely to be married early, often against their will, risking premature childbearing. This, in turn, tragically leads to higher rates of maternal mortality for them personally and contributes significantly to infant and child undernutrition in their offspring. It perpetuates a difficult cycle that is incredibly difficult to break without targeted intervention.
So if we're seeing these stark disparities and distinct challenges across age groups and regions, it begs a deeper question. What really drives these disparities? Let's transition now to the roots of health, looking at the profound impact of social determinants and economic realities. It's often broadly stated that a nation's wealth directly dictates its health outcomes, and the gross national income, or GNI, certainly accounts for much of the differences in child mortality rates we see between countries. But here's where it gets really interesting, and perhaps counterintuitive. Our source points out that it's not just about how rich a country is overall, it's critically about how that wealth is distributed and what opportunities it genuinely provides to all its citizens. For example, despite the immense wealth of the United States, seventh globally in GDP per capita in 2022, its child mortality rate is ranked a shocking 47th in the world. 6.5 deaths per 1,000 live births. That's higher than countries like Cuba, 5.1, Canada, 4.9, the UK, 4.3, the Czech Republic, 3.2, and even Japan, 2.5. This data fundamentally challenges the assumption that sheer economic power automatically translates to uniformly better child health for everyone within that nation. It truly highlights the internal inequalities.
That's a crucial paradox the data presents. And these national estimates of mortality truly mask significant differences in health status among subpopulations within the same country. You see this vividly when you look at educational attainment levels or wealth quintiles. For instance, in Burkina Faso, the child mortality rate was a staggering 43.7 per 1,000 live births among children born to mothers with no education. Yet that rate dramatically drops to 16.7 per 1,000 among children born to mothers with at least secondary education. That's a huge difference. Similarly, in Bolivia in 2016, the child mortality rate was 18.6 per 1,000 for children in the richest wealth quintile, whereas it was a devastating 55.1 per 1,000 for children living in the lowest quintile.
So what you're saying is that within a country, a mother's education level or a family's economic status can be as significant or even more significant than the overall national wealth when it comes to child survival.
Exactly. The source beautifully articulates that child health is profoundly influenced by a complex interplay of socioeconomic factors that operate at multiple levels of society. Disparities in these factors translate directly into profound child health inequities, reflected by persistently high rates of disease, poor nutrition, and disability. The textbook presents this through a socio-ecologic model, outlining immediate, underlying, and basic structural determinants of disease, malnutrition, and disability. While many medical interventions focus on the immediate causes of poor health, treating an infection, for example, the critical insight here, the real aha moment for professionals in this field, is that inequities in child mortality and morbidity will absolutely persist unless those more fundamental, systemic, basic, and underlying determinants of health are comprehensively addressed. You simply can't treat the symptoms effectively without addressing the root causes. It just doesn't work long term.
And it sounds like these roots often extend deeply into economic and broader political environments, which have played a significant historical role.
They absolutely do. The root influences on a child's health often lie in the large-scale economic and political environments in which they are born and raised. The first half of the 20th century saw clear economic growth associated with dramatic health improvements across many regions, falling mortality rates, rising life expectancy. However, the second half of the 20th century was starkly characterized by growing disparities in global economies and health, both between and, crucially, within many countries.
And this isn't just an abstract concept. Our source provides hard data on this growing wealth gap, illustrating how it impacts health.
Yes, the numbers paint a stark picture. According to the World Inequality Report, between 1980 and 2016, the richest 1% of the world's population reaped twice as much of the world's income growth, a staggering 27% as the poorest 50% of the world, who only saw a meager 12%. And while almost all countries report population-level income inequality, some, like the United States, have seen income disparities reach historical proportions. Since 1980, for example, the bottom half of Americans captured only 3% of the total growth in national income. Just 3%. This growing income inequality directly translates into greater differences in health outcomes, such as stark divergences in life expectancy between the rich and the poor. This raises an important question for all of us, doesn't it? Does rising tide truly lift all boats, or do some remain tragically stranded without deliberate policy choices that prioritize equity? Our source provides a compelling contrast, noting that Europe, for example, shows significantly lower levels of income disparities. This is largely attributed to more aggressive redistribution of wealth through taxes and transfers, stronger labor protections, and universal access to fundamental services like education and healthcare. These are not accidental outcomes. They are direct policy choices that profoundly impact the social determinants of health and, consequently, child well-being.
So what you're saying is that inequality isn't just a moral or human rights issue, but the textbook also makes a strong economic case that it's detrimental to growth itself.
Exactly. The evidence compellingly supports the notion that inequalities are not just a human rights issue, but are detrimental to overall economic growth itself. Wealthier households tend to save a larger percentage of their income, which can dampen aggregate demand and slow down economies. Poorer households, on the other hand, face significantly greater challenges in investing in crucial human capital, like health and educational opportunities for their children. This translates into less productive human capital across the workforce, creating obstacles for them to be economically productive and contribute to the broader economy. In extreme cases, deep inequalities can even threaten social unrest and political instability, which further undermines economic activity and development.
And global disparities have been further exacerbated, it seems, by the policies of international financial institutions. This is a complex but crucial point from the source.
It's a critical, historical, and ongoing dynamic. Global disparities have indeed grown significantly between many wealthy and low-income countries, largely due to austerity measures, often termed structural adjustment programs. These were imposed on many post-colonial countries by influential institutions like the International Monetary Fund, IMF, and the World Bank. To receive vital loans and restructure their national debt, many of these countries were effectively required to take on austerity measures. These measures compelled their economies to prioritize producing cash crops and exporting natural resources to high-income countries, often at the expense of nurturing local industries and, critically, investing in human capital and fundamental social services like health and education. This profound shift away from supporting local economies and social service systems severely limited their ability to provide basic services to their growing poor populations. It also critically hindered their capacity to respond effectively to widespread communicable diseases like HIV/AIDS, and even to the growing prevalence of non-communicable diseases. It was a trade-off that had profound, often devastating, and long-lasting consequences for public health and child well-being.
Now, let's turn our attention to a truly seismic event that profoundly shaped global health, even if its direct impact on children was often less severe than on adults, the COVID-19 pandemic. How exactly did it affect global child health, both directly and indirectly?
The emergence of SARS-CoV-2, leading to the global COVID-19 pandemic, resulted in a devastating toll. Over 6 million deaths, over 499 million confirmed cases worldwide. Just staggering numbers. While it's generally true that children and adolescents thankfully experience less severe illness and fewer direct deaths from SARS-CoV-2 compared to adults, this fact can be a bit misleading. It may have contributed to lower rates of testing among children, which in turn could have inadvertently contributed to broader community transmission. The textbook provides a nuanced view, looking beyond just the direct mortality figures.
Right. But even with that generally lower direct impact, the data still shows significant disparities in pediatric deaths, particularly along income lines.
Absolutely. Early evidence confirmed that pediatric deaths from COVID-19 were significantly greater in low and middle-income countries compared to high-income countries. One study cited in our source estimated 2.77 pediatric deaths per 1 million children in LMICs, compared to a much lower 1.32 per million in HICs. And the death rate among infants under 1 year of age was particularly stark, 1.30% in LMICs versus a much lower 0.07% in HICs. So what does this all mean? Even if pigs were less affected directly, the pre-existing structural inequalities and vulnerabilities in LMICs meant the pandemic still hit children in those regions incredibly hard. It just exacerbated the very disparities we just discussed.
What made LMICs particularly vulnerable to these disproportionate impacts, despite some potential protective factors like younger populations?
Well, it's true that some LMIC settings did possess certain protective factors, like a generally younger demographic profile, maybe a lower initial prevalence of chronic conditions, less international travel in remote areas. But these were severely and overwhelmingly offset by profound systemic limitations. These included a pervasive lack of personal protective equipment, PPE, chronically poor ventilation of indoor spaces in many public and private settings, and a deeply inequitable distribution of COVID-19 vaccines globally. That was huge. Furthermore, marginalized groups within these nations who did become infected often faced inadequate medical support and supplies, which could greatly elevate their risk of death and long-term disability. And, critically, poor availability of testing in these regions led to a large number of deaths and infections being severely underreported, obscuring the true scale of the problem and hindering effective public health responses.
So it wasn't just the direct viral impact, but the indirect rippling effects of the pandemic that posed an even greater, perhaps more insidious, threat to children in these regions.
That's a crucial distinction, and the source emphasizes this heavily. The pandemic significantly strained already weak health and public health systems in LMICs. This raised grave concerns about the heightened risk for youth with chronic conditions whose care was disrupted. The COVID-19 impact led to widespread disruptions in routine childhood vaccinations, a severe lack of medical supplies, critical shortages of health workforce personnel, and a reduced delivery of life-saving services like cardiac surgery. One estimate cited a shocking statistic. 90% of countries reported disruptions in essential health services like routine immunizations and essential medicines, even with some mitigation efforts in place. This created a profound health debt for the future.
And the economic fallout had a direct, devastating effect on child poverty.
Indeed. The economic crisis, precipitated by COVID-19 lockdowns and global supply chain disruptions, placed the greatest strain on low-income communities. It drastically increased the proportion of children who live in extreme poverty and face profound housing instability. The textbook reveals a truly alarming figure. An estimated additional 100 million children are thought to have fallen into extreme poverty worldwide. This marks the first increase in this critical indicator in 20 years, a major reversal. Pre-existing disparities widened dramatically during the pandemic, both within countries, exacerbating internal inequities, and globally between LMICs and HICs.
It sounds like the pandemic didn't just cause new problems, it exposed and exacerbated every existing vulnerability.
It absolutely did. The COVID-19 pandemic severely stressed the social fabric of communities globally, with the most marginalized and vulnerable populations consistently bearing the brunt of its full impact. Many racial and ethnic minority groups, for instance, were unequally affected, experiencing significantly higher rates of illness and death from COVID-19. Vulnerable communities that already existed before the pandemic, those living in poverty, employed in informal sectors like street vendors, living in crowded conditions, unable to afford to stay safe at home, lacking protective gear at work, without access to adequate health care and health insurance, all were at much greater risk for COVID-19 infections and their devastating consequences. It was a perfect storm that shone a harsh light on existing inequities.
And the prolonged school shutdowns, particularly in LMICs, must have had profound long-term effects beyond just academics.
Devastating, particularly for children in LMICs, who were especially vulnerable because of the prolonged shutdown of schools. This resulted in significant, often irreversible, loss of education, particularly for those without access to technological online solutions to continue learning. But the impact went far beyond academics. The loss of safe school environments has also been directly attributed to further widening gender inequities in many regions. Tragically, several countries reported a surge in adolescent pregnancies, domestic violence, and child abuse in the wake of school closures. These are consequences that ripple through generations.
And then one of the ultimate silent tragedies, orphanhood and the loss of primary caregivers.
That's another critical long-term consequence with devastating human impact. The number of children affected by COVID-19-associated orphanhood and caregiver death has been estimated to have increased by a shocking 90%. The loss of a mother, in particular, is intrinsically associated with increased child mortality, especially when maternal death occurs in the child's first year of life. In regions where rates of maternal death were already tragically high, the impact of COVID-19 leading to the loss of a mother or another primary caregiver can have truly devastating short and long-term impacts on the lives and future trajectories of children. It disrupts their development and well-being in profound ways.
And finally, the mental health impact. This is something we've seen discussed widely across all demographics, but particularly for children and adolescents.
Yes, an epidemic of poor mental health has demonstrably followed the COVID-19 pandemic for both parents and their children. As the pandemic progressed, the prevalence of depression and anxiety symptoms among adolescents escalated significantly. This profound impact on mental health is not surprising, given the extraordinary disruption of routines, the loss of recreational outlets, the strain on family income, the severe reduction in crucial peer interaction, and the disruption of vital school support systems. To make matters worse, the pandemic simultaneously halted mental health services in 93% of countries worldwide, even as the demand for these services dramatically increased. This was particularly acute in settings where online mental health services were not a viable option. It truly created a perfect storm for a burgeoning long-term mental health crisis among young people.
So with all these complex, deeply interconnected challenges laid bare by the pandemic, how do global efforts aim to tackle them? This leads us to our next section, which offers a blueprint for progress, focusing on the Sustainable Development Goals, or SDGs.
Global development and international aid have long been guided by ambitious international goals, and the current framework is a direct evolution of past efforts. In 2015, world leaders agreed to 17 interconnected goals, universally known as the Sustainable Development Goals, or SDGs, with the overarching aim of significantly improving global well-being by 2030. These SDGs were actually built directly upon the foundation of the 8 Millennium Development Goals, or MDGs, which were specific, measurable targets set by the UN back in 2000. Things like eradicating poverty, hunger, illiteracy, and disease by 2015. So it's not starting from scratch. It's an evolution, a deepening of global ambition with lessons learned.
And the SDGs became even more critical in the immediate, chaotic wake of COVID-19, didn't they? Almost like a renewed urgency.
They absolutely did. The SDGs became even more critical for countries as they planned how to mitigate the future impact of the COVID-19 pandemic on child health, particularly among marginalized communities and LMICs. The SDGs now crucially highlight recommended interventions for countries to meet their goals, especially in the face of these pandemic-created challenges. This includes innovative solutions like optimizing digital centers to increase access to public services, with a critical emphasis on targeting solutions specifically for communities with low internet connectivity, really trying to bridge that stark digital divide exposed during the pandemic.
So the pandemic, despite its devastation, ironically highlighted the need to double down on these development efforts rather than abandon them or shift focus.
Precisely. While COVID-19 undeniably caused significant setbacks in progress toward meeting many of the 17 SDGs, it also starkly highlighted the urgent, existential need to prioritize fundamental public health programs. This includes routine immunization services, widespread malaria bed net distribution, accessible family planning services, and comprehensive antenatal care. The textbook stresses that these basic essential services, often the first to suffer during crises, are absolutely paramount for preventing further negative impacts on child health. It's a powerful reminder that sometimes the most sophisticated solutions depend on the robust delivery of the most basic services.
And one of the SDGs, SDG 3, focuses specifically on health, but our source points out it's much broader than just treating individual illnesses, correct?
Yes, SDG 3 is specifically dedicated to ensuring healthy lives and promoting well-being at all ages. It includes very specific, quantifiable health-related subtargets, like reducing the under-5 mortality rate to 25 deaths per 1,000 live births and the neonatal mortality rate to 12 deaths per 1,000 live births by 2030. But what's truly fascinating here, and represents a significant shift in global thinking, is that SDG 3 is not isolated. It recognizes health as fundamentally interwoven with social, economic, and environmental factors. The other 16 SDGs, for example, focus mainly on these upstream determinants of health, strengthening health systems, addressing socioeconomic factors, confronting gender-based issues, ensuring political stability, and tackling critical environmental concerns.
So it's a truly holistic, interconnected approach, acknowledging that health isn't just a clinic issue.
Exactly. This reflects a vital shift to broaden the global targets to include those fundamental determinants of health. as a social movement to support truly sustainable development. The SDGs were founded on the profound recognition that the world's environment, its economic and social development, and human health are all inextricably interconnected and interdependent. They were formulated with core principles and values centered on achieving economic development, ensuring environmental sustainability, and promoting social inclusion for all people. This approach challenges us to think more broadly, and it raises an important question for you and for our listener. What stands out to you most about this holistic approach to health? It emphasizes that health is not an isolated issue, but a profound mirror of a society's overall well-being and justice.
That's a powerful point. For me, what really stands out is how this forces us to move beyond individual interventions to truly systemic change. It's about the whole picture. And building on the SDGs, our source also details the Global Strategy for Women's, Children's, and Adolescents' Health 2016-2030. How does this strategy fit into the broader SDG framework?
Yes, this strategy is specifically designed to map out precisely how to achieve the health-related SDGs by centering on the ambitious goal of health for all women, children, and adolescents. It emphasizes utilizing evidence-based approaches and, crucially, backing these efforts with innovative and sustainable financing mechanisms. A particularly important component of this global strategy, reflecting a key challenge we discussed earlier, that neglected adolescent period, is the explicit inclusion of adolescents as central to the 2030 Agenda for Sustainable Development. It's an intentional effort to integrate their well-being into the core of global health planning.
And it has 3 core pillars of action, right? It sounds incredibly comprehensive.
Yes. In direct alignment with the SDGs, the global strategy focuses on 3 crucial interlocking pillars of action. First, it aims to definitively end preventable deaths among women, children, and adolescents, a direct call to eliminate the tragedies we've discussed. Second, it focuses on ensuring their fundamental health and well-being. This is broader, meaning ending malnutrition, ensuring universal access to family planning, significantly reducing exposure to environmental pollution, and achieving comprehensive universal health coverage. And the third pillar is expanding enabling environments. This involves large-scale societal efforts, eradicating extreme poverty, ensuring access to good quality education for all, eliminating all forms of violence against females, enhancing global research and tech capabilities in health, and actively encouraging innovation across all these domains.
This sounds incredibly ambitious, and it has a very strong emphasis on equity, which feels different from maybe some past efforts.
That's a key distinction, and it's a profound shift. In addition to being much broader in scope than many previous global health efforts, the global strategy places a heavy, deliberate emphasis on equity. This means the strategy is explicitly designed to apply to all people, including the most marginalized and difficult-to-reach populations, and in all situations, including during acute crises, conflicts, or pandemics. So, for example, health insurance coverage isn't just assessed based on a national average. Critically, it's assessed by how well the increases in coverage actually benefit all population groups, regardless of their income, their educational level, their geographic location, or their social status. It's a profound shift towards genuine inclusivity and justice in health.
Okay, so with these ambitious goals in mind, let's now transition to something concrete. What are the specific evidence-based interventions and innovations that our source highlights as actually capable of moving the needle on global child health? This is where the rubber meets the road, really.
This is truly the hopeful part of the deep dive. The good news is that expert estimates suggest most of the 5.6 million annual deaths in children younger than 5 could actually be averted simply by significantly increasing the implementation of proven, often low-cost interventions that we already possess. For instance, childhood deaths from diarrheal illness and pneumonia, 2 of the leading causes globally, can be prevented by remarkably simple yet powerful measures like widespread vaccinations and consistent exclusive breastfeeding until 6 months of age. Deaths related to undernutrition, which, as we discussed, profoundly predisposes children to infectious diseases and long-term developmental issues, can be prevented by proper infant and young child feeding practices, targeted micronutrient supplementation, and community-based screening and management of malnutrition. The knowledge is there. The challenge is scaling it effectively.
And it's not just about delivering one-off interventions, is it? Our source points to the importance of a continuous life course approach.
Exactly. Addressing the SDGs to truly improve the health of mothers, children, and adolescents fundamentally requires a life course approach. This means recognizing that health outcomes are shaped across a continuum of care, from pre-pregnancy through adolescence, and that interventions at any stage can have ripple effects later on. The data, often illustrated through figures like those in our source, reveal wide ranges of intervention coverage rates within countries. This powerfully highlights that it's not just about having the interventions available somewhere, but about making absolutely sure they actually reach every single person who needs them consistently throughout their life.
Vaccines are often hailed, and rightly so, as one of the greatest public health success stories in human history. What's their specific impact in this context, and where are the lingering critical gaps?
Vaccines are indeed a phenomenal triumph of public health. Our source highlights their immense impact. They prevent an estimated 2.5 million deaths per year among children under 5. One study even went so far as to predict a reduction of 120 million deaths among children born between 2000 and 2030, just with the continued expansion of vaccination programs. Huge numbers. Yet despite this incredible life-saving impact, significant and deeply concerning gaps remain. In 2019, an estimated 1.15 million under-5 deaths were still the direct result of vaccine-preventable diseases, with a staggering 99% of these children living in low- and middle-income countries. The top contributors to these preventable deaths were Streptococcus pneumonia and rotavirus, followed by Bordetella pertussis, whooping cough, measles virus, Haemophilus influenza B, Hib, and influenza.
So the vaccines exist, they're proven, but the reach, the distribution isn't universal. That seems to be the crux of it.
Precisely. The WHO Expanded Program on Immunization, or EPI, has achieved dramatic reductions in deaths, illness, and disability from many of these diseases, even leading to the near elimination of poliomyelitis globally, which is incredible. However, the inherent vulnerability of these programs was starkly demonstrated during the COVID-19 pandemic. Global vaccine coverage dropped from 86% in 2019 to 83% in 2020. That might not sound huge, but it meant an estimated 23 million children under 1 year didn't receive basic vaccines in 2020. That's the highest number since 2009. This significant decline dramatically increases the risk for a resurgence of these vaccine-preventable infections, especially amidst already weakened healthcare systems.
And this challenge of reaching every child everywhere seems to be a recurring theme, not just with vaccines, but across other life-saving interventions, too.
It absolutely is. Global vaccine organizations aim for universal coverage, but they continually face complex, multifaceted challenges within countries to attain this crucial goal. It's not just vaccines either. Other incredibly simple yet life-saving interventions also encounter persistent barriers to universal coverage. Take oral rehydration therapy, or ORT, for example. It has been the evidence-based, highly effective intervention to prevent dehydration from diarrheal disease since the 1970s. Simple salt and sugar solution. Yet, tragically, our source tells us that only 2 in 5 children under 5 with diarrheal illness actually receive this treatment, just 2 in 5. This starkly highlights that whether a child receives a life-saving intervention is multifactorial. It depends on complex characteristics of the healthcare system, deeply ingrained social attitudes and practices within communities, and the broader political climate and commitment to health.
So it's about much more than just having the medical solution. It's profoundly about how that solution is delivered to the people who need it most.
Exactly. Innovations designed to strengthen vaccine coverage to genuinely reach every child in every district range from programs like Reaching Every Child Through Quality Improvement, or RECQI, which use sophisticated community mapping techniques, to the comprehensive integration of service delivery mechanisms and the strengthening of the entire health system with improved surveillance. It's about understanding that these are systemic challenges requiring systemic improvements, not just individual medical interventions in isolation.
And this leads us directly to the concept of integrated management of childhood illness, or IMCI. What exactly is that, and how does it aim to address these systemic issues of delivery?
Well, weak health systems themselves are a major, often insurmountable, impediment to a country's ability to effectively deliver cost-effective interventions and vital life-saving health messages for children. These systems are often characterized by insufficient numbers of trained health workers, low-quality training and supervision for those who are available, and chronically poorly functioning supply chains for essential medicines and equipment. While individual child health services might focus on a single level, say a central health facility, effective and lasting improvements can only truly be achieved with the profound integration of delivery at all levels. That means adequate referrals and seamless follow-up between the community, the local clinic, and the larger health facility. As countries now resume and rebuild health services after the profound disruptions of the COVID-19 pandemic, a crucial component will undoubtedly be robust, community-based, life-saving outreach services. Things like mass immunization campaigns, vitamin A campaigns, and comprehensive community-based health promotion.
So it's about shifting the paradigm to actively get health care to the people rather than just passively expecting them to come to a central facility.
Precisely. This is where community health workers, or CHWs, become absolutely indispensable. They are members of a community, often without formal medical training, specifically chosen and trained to provide basic health and medical care directly within their own community settings. The problem historically has been a pervasive lack of integration of programs that deliver individual interventions. This leads to countless missed opportunities. For example, a child might get immunized by one health worker, but then have to navigate an entirely different system to get ORS for diarrhea, and yet a third path for malnutrition treatment. Past programs often focus narrowly on a single disease and specific set of interventions. But in reality, most children present with overlapping signs and symptoms to community-level facilities that often have very limited diagnostic tools.
And that's where IMCI steps in to bridge and integrate all of that fragmented care.
That's the core, brilliant idea. The Integrated Management of Childhood Illnesses, or IMCI, was comprehensively launched in the mid-1990s by UNICEF and WHO as a truly holistic approach. Its goal was to reduce child death, illness, and disability, and to vigorously promote improved growth and development in countries struggling with persistently high child mortality rates. IMCI was specifically designed to significantly increase coverage of evidence-based, high-impact interventions that tackle the top causes of child mortality by intelligently integrating health promotion, illness prevention, and crucial disease treatment into a single, cohesive framework.
So it covers both prevention and treatment, and it empowers community health workers to deliver it.
Yes. IMCI contains both preventive and curative elements set forth through a series of clear clinical algorithms and practical guidelines for case management. These are then implemented at multiple levels, by families themselves, within communities, and by providers at health facilities. A key transformative component of the IMCI strategy is to specifically train those community health workers to use these algorithms. They learn to identify critical signs of common childhood illnesses and to make informed decisions about when a child needs immediate referral to a health facility for more advanced care. They're also trained to instruct parents on essential home management, giving ORS and zinc for diarrhea, appropriate antimalarials for kids with malaria, even antibiotics for signs of pneumonia. Beyond treatment, CHWs schedule crucial follow-up visits and actively promote essential health behaviors like bednet use, hand washing, and optimal feeding practices. In 2003, the guidelines were wisely updated to include newborn care for babies under 1 week old, and it was renamed Integrated Management of Newborn and Childhood Illnesses, or IMNCI.
And what's been the tangible impact of this comprehensive integrated approach? Has it genuinely worked on the ground?
The adoption has been significant. Over 100 countries have adopted IMNCI and implement some or all of its components. This includes improving health worker skills, but also strengthening health systems and community practices. A recent review after 20 years of implementation notably found that IMNCI was associated with a 15% reduction in child mortality when its activities were properly implemented in health facilities and communities. That's a highly significant impact. However, the implementation of IMNCI has regrettably been uneven both between and within countries. In many places, the foundational resources for CHW training and supervision, the consistent supply of essential medications, and the necessary referral systems were limited or, tragically, completely absent. IMNCI was only truly successful and impactful in those countries with strong government leadership, a sustained commitment, and robust partnerships with support from groups like UNICEF and WHO. It unequivocally requires an adequate health system and a systematic, unwavering approach to planning and implementation to truly succeed.
Beyond these direct medical and health system interventions, our source also highlights the growing and powerful role of social protection programs, often involving direct financial incentives. This is a fascinating area.
Yes, financial incentives are increasingly recognized and utilized as a powerful tool to improve healthcare coverage, directly alleviate poverty, and crucially, improve access to child health services. In industrialized countries, cash transfers are already a common, established mechanism to ensure that the poorest, most marginalized subgroups, particularly those with children, receive adequate support to meet basic needs. Even before the COVID-19 pandemic, cash transfer schemes were gaining significant traction in LMICs to support vulnerable populations. The pandemic, in fact, remarkably led to an enormous elevation and rapid expansion of social protection efforts as a critical, immediate response to mitigate its far-reaching impact. Many profound lessons have been learned during this rapid escalation, which provides genuine hope for continued support of families in need, plus a crucial expansion of these services to mitigate the projected dramatic increases in children living in extreme poverty.
So it's about directly addressing the deep-seated financial barriers to health, which we know are so pervasive in many settings.
Exactly. Out-of-pocket expenses by households form the major share of total health expenditure in most LMICs. This creates an immediate, often insurmountable, barrier to accessing care. Many social protection programs serve a dual vital purpose. They directly reduce financial barriers, and simultaneously, they can strengthen service delivery by creating demand. These financial incentives can take various forms: direct cash transfers, microcredit opportunities, health-specific vouchers, the strategic removal of user fees at clinics, and the provision of health insurances.
And these programs can be conditional or unconditional. What's the difference, and why does that distinction matter so much for outcomes?
Yes, that distinction is crucial. Unconditional programs provide financial support to eligible families without any specific requirements or expectations on how the money is spent. This approach is based on the belief, and often the evidence, that families, particularly mothers, will use this support for their children's best interests. It provides flexibility. Other incentives, however, are conditional on families undertaking specific health promotion behaviors targeting child health. For instance, cash or vouchers might be conditional on families participating in mother groups for breastfeeding support, making regular clinic visits for vaccinations or growth monitoring, engaging in deworming programs, or ensuring kids get vitamin A and iron supplements. Some social protection programs are also smartly directed towards educational improvement by making cash transfers conditional on child school enrollment, consistent attendance, or occasionally even academic performance.
Here's where it gets really interesting. We're seeing how direct financial support can be an incredibly powerful tool, not just for poverty alleviation in a general sense, but specifically for improving measurable health outcomes. What stands out to you about how these programs influence behavior, and how has the pandemic accelerated innovation in this area?
What truly stands out to me is their multifaceted potential. They provide immediate essential relief and effectively reduce debilitating financial barriers, for sure. But the conditional programs in particular also serve as powerful nudges or incentives for families to adopt specific, evidence-based health and education behaviors. They kind of bridge the gap between simply knowing what's healthy and genuinely being able to access it or implement it consistently. During the pandemic, we saw a remarkable, rapid scaling of innovations that powerfully leveraged data and technology. Mobile cash transfer programs, for example, became a critical lifeline, allowing governments and NGOs to better target those most in need and get vital support to them quickly, even during severe lockdowns. These efforts are particularly crucial for certain countries projected to have protracted recovery periods from the pandemic's economic shock. International support is now being strategically channeled to identify and aid these poverty hotspots, making this an evolving space that intelligently combines economic aid with precise public health strategy.
Okay, even with all these ambitious goals and these proven interventions and innovative strategies we've just discussed, our source makes it clear that there are still some incredibly persistent foundational hurdles in global child health. Let's delve into these major, often overarching challenges.
One of the most significant and strategically important areas, perhaps the key to unlocking future progress, is adolescent health. The global strategy, which directs countries to achieve their SDGs, has specifically called upon nations to significantly focus efforts on supporting adolescent health. This has given its immense, often underestimated potential role in breaking the intergenerational cycle of poverty that we discussed earlier. It's really an investment in the future workforce and the next generation of parents.
But there are still considerable challenges, aren't there, in actually convincing governments to invest meaningfully in this age group? It seems like they often fall through the cracks.
Yes, a key challenge to attaining these ambitious health goals will be to effectively advocate for and demonstrate to governments that investing in this age group is not just a social good, but a powerful means to significantly improve national productivity and the broader economy in the long term. There are also considerable persistent gaps in reliable data on adolescents, which pose one of the biggest challenges to truly promoting their health and rights. Data on early adolescents, those aged 10–14 years, is particularly scarce, significantly limiting our comprehensive knowledge of this crucial developmental period. Efforts to actively promote youth participation in delineating their own health priorities are absolutely essential for designing effective interventions that genuinely meet their diverse needs and resonate with their lived realities. We need to listen to them.
So empowering them through education, particularly girls, is identified as a critical multi-pronged strategy.
Absolutely. One critical strategy specifically highlighted in the source to support adolescents and break cycles of poverty is to profoundly improve completion of secondary school education, particularly among girls. The development of adolescents' capacities and values through education can empower an entire generation to become economically independent, to become active, positive contributors to society, and to decisively break out of the cycle of poverty and poor health that has constrained their families for generations. It's a long-term investment with potentially exponential returns.
Beyond the immediate issues of poverty and education, what are some of the other key health threats and challenges specifically facing adolescents that our source identifies?
Other significant threats to adolescent health include a rising tide of mental health issues, challenges related to substance abuse, complex sexual and reproductive health needs, and the growing burden of non-communicable diseases, NCDs, such as obesity, which vary depending on the country and its stage of epidemiologic transition. The surge in adolescent pregnancies reported in several countries during the COVID-19 pandemic places particular emphasis on the urgent, ongoing need to strengthen youth access to comprehensive sexual and reproductive education and services. A common theme across many of these threats is that interventions must actively attempt to influence individual behavior and attitudes while simultaneously promoting healthy lifestyles through a supportive environment. It's both individual and societal.
And the mental health crisis among adolescents is particularly alarming, with some sobering statistics in our source.
It truly is. It's estimated that around 20% of the world's adolescents have a mental health or behavioral problem, and this already high prevalence has only escalated further since COVID-19. Depression, for example, is identified as the single largest contributor to the global burden of disease for people aged 15–19. That's huge. And tragically, suicide remains one of the top 3 leading causes of mortality among people aged 15–35. Tackling these profound problems will require a robust interdisciplinary approach, with significantly more dedicated research needed to identify and rigorously evaluate effective interventions specifically tailored for adolescent behavior in LMIC settings, where resources are often scarcest.
Moving on to an even broader, overarching threat that spans beyond just health, but profoundly impacts it: climate change. How does this environmental crisis impact child health?
Climate change is unequivocally described in our source as the most urgent and alarming long-term threat to child health and well-being in this century. There's no ambiguity there. Its impacts are pervasive. It directly contributes to widespread environmental degradation, the loss of vital natural resources, and profound, unpredictable changes in climate patterns that directly undermine essential food and water sources for communities globally. Climate change, along with an increased frequency and severity of humanitarian crises, from floods to droughts to extreme heat, has already demonstrably and adversely affected children's health and nutrition worldwide. The call to action is clear and urgent. Sustained advocacy at local, national, and international levels is desperately needed to reduce greenhouse gas emissions and mitigate these devastating, escalating impacts on the youngest and most vulnerable.
And then there's the immediate, brutal reality of conflict, emergency situations, and large-scale migration. These create extreme vulnerability for children.
During times of crisis, whether armed conflict, natural disaster, or other emergencies, children, adolescents, and women are consistently identified as the most vulnerable populations. While the youngest are most likely to perish due to disease or injuries during these events, all children suffer immensely. This includes enduring severe food shortages, living with poor water and sanitation infrastructure, experiencing profoundly interrupted education, and facing the deep trauma of family separation or forced displacement. The scale of this issue is immense. Approximately 281 million migrants live outside their countries of birth globally. This figure includes 35 million young children and adolescents under 20 who have migrated either with parents or, tragically, as unaccompanied minors. And many other children are deeply affected by migration through parental separation due to deportation or emigration, even if they don't migrate themselves.
And these children, especially those crossing borders, often don't have the same protections or rights as residents, making them even more vulnerable.
Unfortunately, that's a key compounding factor. Children and adolescents crossing international borders often are not entitled to the same protections and rights as those who reside in a given country. This leaves them at much greater risk of discrimination, exploitation, and even outright abuse. A robust, rights-based approach to migration is urgently required to reinforce the steady buildup of support and attention to migration issues at both international and national levels. This approach must address not only the profound long-term social and health consequences of migration, but also, critically, the root causes of migration itself: instability, profound inequality, discrimination, pervasive poverty. Critically, it should incorporate policies specifically targeted for young children, adolescents, young women, and all vulnerable populations, including those tragically left behind when family members migrate away. Recognizing the unique adverse childhood experiences these circumstances create and their profound long-term health effects is vital.
Finally, let's talk about health information and communications technology, or HICT. It sounds like a bit of a double-edged sword. Immense potential for progress, but also significant systemic barriers, particularly in low-income settings.
It absolutely is. The widespread proliferation of health information and communications technology has already profoundly transformed healthcare in many parts of the world, offering incredible promise. Social media platforms and mobile applications, for instance, can be powerful tools to rapidly raise health awareness and build crucial health-related skills, especially in LMICs where other channels for public health messages might not be as accessible or effective. The potential for rapidly disseminating vital, accurate health information is enormous.
But as you said, the dissemination hasn't been equitable across the globe. The access isn't universal.
Far from it. The majority of low- and middle-income countries are still, unfortunately, in the early stages of comprehensive HICT adoption within their health systems. Many healthcare settings in these regions still rely exclusively on paper-based records or very simple electronic data capture tools like spreadsheets for critical functions like disease surveillance, reporting, and research. The barriers to effectively implementing and scaling HICT and LMICs are substantial. A pervasive lack of foundational health data infrastructures, unreliable internet and electricity access, insufficient workforce training for these new tools, a scarcity of tools that are genuinely fit for local healthcare needs and culture, and a chronic lack of sustainable funding to maintain these complex systems. It's a whole ecosystem problem.
So it's not just about getting the technology itself, it's about building and sustaining the entire ecosystem around it.
Exactly. A further critical challenge is the inherent need to ensure the privacy and security of sensitive health data, while simultaneously standardizing the format in which that data is captured. This standardization is absolutely vital to permit the seamless sharing of health information across different facilities. That, in turn, can reduce costly inefficiencies and significantly improve the overall quality of care delivered. To truly overcome these multifaceted challenges and genuinely advance equitable health outcomes globally, balanced collaborative partnerships between healthcare and technology communities across all income countries, low, middle, and high, are desperately needed. These partnerships are essential to share crucial knowledge, foster continuous innovation, and systematically strengthen health information systems globally to serve everyone, everywhere. If we truly connect this to the bigger picture, what we've unpacked today is a profound understanding that global child health isn't simply a medical issue in isolation. It is a profound, sensitive reflection of a society's deep-seated inequities, its fundamental economic structures, and frankly, its political will.
The data makes it undeniably clear that monumental progress is possible, as we saw with that U5MR reduction. But it is also starkly uneven and deeply tied to those social and economic determinants we discussed. It's truly a complex web of interconnected factors, and understanding that interconnectedness is really what elevates your understanding to that of an elite professional in this field.
You've just completed a truly in-depth exploration with us, cutting through layers of data and complex global issues. And now you possess a much richer, incredibly nuanced understanding of global child health, a true aha moment that gives you that professional level grasp of these critical challenges and the forces at play. We've seen how much progress has been made through focused efforts, but also how much remains to be done, especially for the most vulnerable children and adolescents, and how external factors like pandemics can expose and exacerbate every existing flaw. So what does this all mean for the future? As you reflect on the uneven progress and persistent challenges, particularly the profound impact of global disparities, the often overlooked adolescent phase, and the rippling effects of crises like the pandemic, consider this. How might prioritizing adolescent education and holistic well-being, specifically for girls, unlock disproportionately powerful transformative changes? Not just for individual families and communities, but for entire nations over the next century. What potential is waiting to be unleashed there?
And this raises an important question for all of us, really a call to action. Knowing that significant progress is possible, but recognizing the deeply systemic and uneven nature of these challenges. What role do we all play in advocating for the fundamental systemic changes necessary to ensure every child, everywhere, truly has a genuine, equitable chance to thrive, not just survive? It's a call to look beyond the immediate and consider the foundational shifts needed for a healthier, more just future for all children.